Welcome to the Department of Healthcare Access and Information, or HCI 2022 CBSE Triennial Code Cycle Updates presentation brought to you by the Building Standards Unit here at HCI. As you may know, California amends its building standards every 3 years, so hold on tight and prepare to learn about some of the changes that have been made to the 2022 California Building Standards Codes. This is the third session in a three-part CBSE series, and today we're going to be going over updates for Part 1 and Part 2, Volume 1. If you haven't done so already, feel free to download the PDF copy of this presentation available to you in the Go-To toolbox under the Handout section. We've scheduled to be here for about 2 hours, which includes a question and answer session at the end. But if you have any questions during the presentation, please type the question into the question section of the Go-To panel, and we will try to answer them as we move along through the presentation and at the end of each section, and also at the end of the presentation. Be sure to keep your questions generic and specific to this presentation, but if you do have a specific question that is outside of this presentation, feel free to send that question over to regsunit@hci.ca.gov. That's regsunit@hci.ca.gov. If we experience transmission difficulties, please be sure to log out and log back in using the same login information sent to you by the Go-To software when you registered for the presentation. Today for a presenter, we're going to have Mr. Richard Tannehill, who is a Deputy Division Chief here at HCI. So once again, thank you for joining us. And without further ado, I will hand the presentation over to Richard.
Thank you, Caesar. Hello, everyone. Today we have a lot to cover, but it shouldn't take too long, so there should be plenty of time for questions and answers. But what we're going to do is, as Caesar mentioned, we have code updates every 3 years, and with an intermingling of the intervening code every 18 months. So today we're going to be looking at the 2022 code that comes into effect on January 1st, so 1 month from today. And we'll go ahead and get started. We are partnered with AIA California, so for those that can get health and safety credits, you can self-certify for this through the AIA. They have been notified. And as also Caesar said, we're in session 3, which is kind of did everything backwards this time, but is due to scheduling. But session 3 is part 1, the administrative code, and part 2, volume 1, which is the kind of the architectural section of the building standards code. So as Caesar also said, please bring your questions as we go through. Go ahead and type them into the questions in the chat, and we'll try to take care of them as we're going through the process. As I just mentioned, this is what's considered the 2021 Triennial Code Cycle, which for us is the 2022 California Building Standards Code. And it takes effect January 1st, 2023, 1 month from today. And it's actually we're getting a lot of people trying to submit their projects in this month early to lock in the 2019 code. And I would caution on that because the 2022 code has a lot more flexibility, but people are going to do what they want to do. So as I mentioned, the 2022 intervening code session is actually due today, so we have staff actively working to get that in today. So we are already making changes to what you're going to see today, and I'll try to highlight a couple of those that you'll see today that will actually be changed back as we get into the intervening code. And I'll highlight those as we go through. So as mentioned, we're going to cover part 1, administrative code, and part 2, volume 1 is the non-structural portions of the building code. So how this is done, anything in bold or black text is existing text. There's no change, but it may be bold to highlight something. If it's underlined in blue text is new text. And if it's underlined with a red font, it'll be for emphasis. You'll see some of that. Any gray strikes throughs are text that is deleted, so you can see what's actually being taken away and replaced. And anything in the purple text will be more for reference, and we just have 1 or 2 of those, I think. So we're getting started with part one, California Administrative Code. You may be used to seeing collaborative review and phase plan review, but those have gone away and have been replaced with integrated review. So section 7-111, under the definitions, those other two have been gone and replaced with the integrated review. Now with the integrated, I'm not going to read through this definition, even though I'll probably be reading through some of the others. Integrated review is a combination of phase review and the collaborative review. And what has been set up is it's almost more of a kit of parts. So you can integrate pretty much all components of those other two types of review into the integrated review and customize it to your project. The only exception to that is this does not carry into construction anymore. It's just to get to the permit stage. Okay. But the process to do an integrated review would be the same as you had previously. You still have to submit a request to do these, and we'll cover the fees on these later. So we're going to be covering a lot of small items today just to show you things have changed. So there'll be some pointer changes, some word corrections, but I'm going to try to cover everything so that you do have a better picture of what's covered in the code changes. Some of our other presentations we sat through and we skipped through some of these minutia items because they're really not relevant, but today we're going to provide a full look at what has changed. So the first thing we're going to look at here under definitions under actual construction cost is the definition of equipment here has been clarified that this is construction equipment. So when they're looking at the actual construction cost, it's the, I'm just going to kind of summarize here: excavation, trenching, retaining temporary construction and barriers, materials, supplies, machinery, construction equipment, labor cost are all included under actual construction cost. What was adding confusion was this is not medical equipment. A lot of larger projects, when they have medical equipment, that's under a completely different budget than construction, and we recognize that. So this was adding some confusion to that. Now, there are exceptions for equipment that are included as part of the architectural components of the building, such as imaging equipment, and a lot of the fixed equipment would still be considered in that construction cost. But where this specifically was talking about materials, supplies, machinery, equipment, labor, that's all related to construction. So we also added start of construction, and this is the kind of stepping back a little bit, and most of you know our department, our office has changed the department. We're HCI. We have not updated the code to reflect that, so you're still going to see OSHPD referenced quite a bit because we've actually only made one change to include the HCI, and that's how to get in contact with us. So we're still going to be using OSHPD 1, 2, 3, 4, 5 indefinitely as of right now. So that will remain as is. So there's no such thing as an HCI 1 or HCI 2 building. So what we did for all OSHPD buildings except for the OSHPD 3 is we define the start of construction as the date that actual physical work, demolition, construction, repair, reconstruction, rehab, etc. Takes place, or other improvements or off-site component preparation as shown on the approved documents. And what this is basically stating is the start of construction could be off-site fabrication of steel, preparing, building of elevators, things like that, that if you went out to the site, you don't see anything happening, doesn't mean the construction hasn't started. If you look at the definition that was in the building code, it basically actually requires erection of steel or walls or something to happen. And we recognize that you're not going to see anything physical on site, and that doesn't necessarily mean that construction has not started. So we've added that definition. And just kind of a side note, what was funny is once we did that in this next cycle, the ICC removed their definition of started construction. So ours will remain. For managed projects, again, this is just changing some of the terminology from phased plan reviews to integrated review. You'll see a lot of that here, going from getting rid of collaborative or phase review and just replacing it with the word integrated. And we're also adding what the requirements are for submitting electronic drawings. So in this case, if you don't submit electronic drawings, you still have to provide 2 paper copies. But we're about 99%, if not higher, on electronic reviews right now. And so this shouldn't affect too much of you. But we just revised the language to state if you're providing paper copies, these things apply, or otherwise submit drawings electronically. Again, you'll see some more references to this. Again, renaming phase review to integrated review. I'm just getting rid of, kind of cleaning up the language so it just references the one process. And that would be actually for both parts of these. Integrate, we no longer have a memorandum of understanding for the integrated reviews. It's a integrated review plan, or IRP. The reason for that is if we do an MOU, it's actually a legal document that goes through our legal department and slows things down. By doing an integrated review plan, it actually is done at our local level, so things happen a lot faster. I'm going to pause here as we have a question in the chat. Start of construction, actual date demolition starts. Does this include work done under I'm not sure what that says, a permit? Actual date of construction for demolition does require a permit. So it'd be the date that someone's actually going out to the site and starting to actually work. And the reason this is important, make ready permit, yeah. Yeah, it can be done under a make ready permit. A lot of times these are field reviewed. Demolition permits are pretty easy to get through. So the actual date that demolition starts would be your start of construction. And the reason this is important is that, the IOR has to notify us, or the owner has to notify us when the start of construction is, so we can have staff scheduled to be there and be available for the projects. We have had actually people go out to a site, didn't see anything happening, and basically said nothing started. And again, your timelines, your time limitations for actual work happening is like 1 year. And sometimes people can get in trouble if they don't see anything physically happening on site. But that doesn't mean nothing's happening. So it needs to be very clear to us that work is being done on site or off site, and what that work is, so that we can track it properly.
Richard, as a follow-up question to that, there's another question that says, for new start of construction definition, does that mean that materials submittal process counts?
No. It has to be something physically being built for the project, such as assembling elevators. I use the elevator example because that actually happened. They were assembling elevators. It was an elevator project. They started the assembly of the elevators. So to me, that's the start of construction, but nothing was happening on site. The document review is not part of that. The start of construction is something physically happening to progress the project forward.
So being that something that has to happen physically, can non-permitted work be done ahead of formal start of construction? For example, temp power, trailer, scaffolding, etc.
Non-permanent work?
Permanent work.
Well, all that has to be approved, so no.
Perfect, thank you.
Okay.
And last question we have here before we continue is, does erecting construction barriers count as start of construction?
Yes, it would. And that does require a permit, and then that would count as construction. Any type of make-ready work on site, like I said, if you're physically seeing it, is start of construction. The reason we redefined this was primarily for the off-site construction work that wasn't apparent that work was actually starting, such as, like I said, fabricating steel or erecting, or what's coming up now are these off-site prefab units that would also count as start of construction. Okay.
All right. Looks like we have a couple more questions, but we can answer them now or move forward. Richard?
I'll move forward a little bit because we're almost, part one isn't very long, and we'll hit those at the end of part one.
Perfect.
Okay. For preliminary reviews, we used to have outline specifications are required to be submitted with a preliminary review. We're removing the outline. We need something more than a outline draft of the specs. So they need to be, the specifications need to be started at a level that would relate to the project. For work performed without a permit, we're just removing the definition of estimated construction cost as we have revised it, and it applies under definition. So we don't need to add it under each of these. So it's just removed as redundant. For time limitations, this is something new that will affect most of y'all. If you have a project that with construction cost under $500,000 or $500,000 or less, the turnaround time to get back check comments in is going to be 45 days versus 90 days for a project that's greater than 500,000. The reason for this is these are smaller projects. In order to meet the anticipated approval dates, we need quicker turnarounds on getting drawings back to us so we can finish the reviews. So we are making that change as of January. For time limitations, as I mentioned earlier, there's 1 year from the time the project is approved to the start of construction is required. If construction is suspended or abandoned for any reason for a period of 1 year following its commencement, the office's approval shall become void. Prior to approval becoming void, the applicant may apply for an extension up to 1 year. The office may require that construction documents be revised to meet current regulations. That's all regular text. The extensions must be requested in writing and justifiable cause demonstrated. What we are adding is for the purpose of building permit time limitation, the project shall be considered abandoned when the work of construction, if any, performed during any 12-month period does not result in a minimum of 10% increase in the overall project or construction work for the project based on either its scope or cost, and no extension for the time has been approved by the office. And what that is being added for is we have projects that they may put up a 3 or 4 studs and say we started work within the 1 year, another year goes by, and we literally had those 4 studs removed and say we continued work. So we are requiring 10% of the project to be completed on an annual basis. So that still gives you 10 years to complete a project, but you need to show continuous progress on the projects. For time limitations, this is for integrated review again. And that integrated review is typically a managed project, but what we were doing, we're excluding some of the requirements for managed projects. And I'll jump to the next slide and clarify that. Under 7-129, A and B shall not apply to managed projects. Basically, look what A and B are. Their final construction documents to be submitted to office for 1 year. Preliminary plans, again, there's no reason that should be managed and any exception taken on that. And also procedures leading to obtaining written approval of final construction documents. Again, that has to do with construction. So managed projects are only for plan review. Okay. Just changing phase review to integrated review under 7-130 and just kind of just clarifying the language here. And just so this kind of sounds weird because we just said we removed phased, but a phased integrated submittal is still a real thing. So that is why the wording has been changed there. We just don't have a phased review. Under fees, the fee structure is changing for hospitals. If the project is $250,000 or more, the 1.64% still applies. Again, the definition of estimated construction cost was redundant, so it was deleted. But for projects under $250,000, the fee will be 2% of the estimated construction cost. And that's because the smaller projects do take the same amount of effort to get them up and moving. It's just like if you're doing a project for a client, if with their smaller projects, a lot of the percentage of the fee is typically a little higher than normal just because the additional work on the small projects is still needed. Okay, for skilled nursing facilities, it's still 1.5 no matter what the construction cost is of the project. And for incremental fees, just as it's clarifying that the fees are due upon the first submission of the construction documents for each construction increment. For incremental projects, you're usually paying the fees based on the increment. So the first submission of that increment, that's when the fees are due. For integrated reviews, they will all be at 1.95% because the extra effort involved in processing those and managing them. It has previously been required for collaborative review, so now we're just rolling it into integrated review, so that still applies with the 1.95%. And this part that's been deleted was what I would just mention, that the for collaborative review, we just got rid of that paragraph and rolled it into one paragraph under item 1. Some stuff on IOR work. This is just the IORs are allowed to maintain. I'll just read it. The field. This is what's the added language. Field records shall document the time and date of all significant correspondence with the contractor regarding incomplete work. Potential deficiencies or deviations require the contractor's attention and could potentially affect the timely and compliant completion of the project. Again, if there's anything found that's out of compliance, the IOR must put that in writing and submit it to the contractor. Copies of all the certificates, tags, marks, or other evidence of material and properties or manufactured components as required by the Building Standards Code should be kept on file. And the names and certificate numbers of all special inspectors who perform both on-site and off-site work should be kept. Here we're stating that field records may be kept electronically. Please note down here, electronic records may be retained on-site if made available during on-site and remote review of documents. So in other words, if you're unable, if the IOR is unable to present those documents readily, either remotely or when our staff are on site, paper records may be required. Okay, and we are having a problem with that, with either internet's being down, connection to the internet being down, or just unable to access the documents. And that is a requirement. That should be every site visit that these are presented. So they can be kept electronically, but they have to be available. And that's it for part 1. We'll go through some of these other questions.
Great, Richard. Thank you for that. We have a couple of follow-up questions for the start of construction. One of them is a make-ready permit. Does blocking areas and doing grading count for start of construction?
Okay, grading depends on what part it is. If it's regular site work, and it depends if it's under our jurisdiction. If you're grading the building pad, yes, that does count as start of construction. Setting up barriers, Not necessarily if they're not impacting, if it's, again, if it's the greenfield site, it would be something related to the actual construction of the project. But talk to your compliance officers. Again, this should, anything at that size should have a pre-construction meeting. Talk to them and let them know. Again, keep us informed. Just all it is all we're requiring is the communication for start of construction. So what we're trying to avoid is a facility that's not intending to start construction. So they set up chain link fence and some construction barriers out on the site. That doesn't mean they're starting construction. That doesn't mean they have another year to sit on that. So the idea is that they're actually doing something physical for the building process.
Great. Now, moving on to construction cost. This is more of a confirmation. So what they're looking to confirm is that construction costs to not include medical equipment except built-in medical equipment, MRIs, booms, etc. Please confirm.
Yeah, that's how I would see it. All the rolling mobile stuff that comes in after the fact is, like I said, usually the facilities have a separate budget for that. That's not part of their construction budget. But the imaging equipment, the fixed equipment, the central plant equipment is all part of the construction of the building.
All right, now we're going to move on to the 10%. And these are two questions. I'll put them together. The first question reads, who qualifies the 10%, the owner, IOR, or DPOR? And then the second part of that was, how does HCI determine the 10% progress?
Well, every time they go out on site, there's a report that's done that identifies the percentage of construction that's been done. If they're showing progress being made, this is not going to be questioned. It's the ones that are stagnant, that maybe you're getting 1% or less of the work being done out there. That's when we have issues. So the 10% is, again, the IORs state what percentage they're at. Our field staff state what percentage they think it's at. If they're showing significant progress, approximating about 10% a year, that's not going to be an issue. Even if it's like 8 or something, that's not going to be an issue. You're showing continued work on the project. What this is really set up for is to avoid the projects that just sit there. We have projects that have been open for 12 years with nothing really ever built, and that's what we're trying to avoid.
Perfect, Richard. Moving on to the IOR documentation. The question reads, isn't 4.6, isn't that what an oil is for? Are you asking for duplicate documents?
Can you repeat the question, please?
Yes, the question reads, 4.6, isn't that what an oil is for? Are you asking for duplicate documents? I believe they're referring to the IOR documentation, having to note what is deficient, what the issues are on the project.
The oils list is a tool. It's not part of it's a tool that the IOR or the contractor or even us, we all have our own versions of the oils list. The IOR, again, I'm not sure I'm understanding the question, but if the IOR is seeing deficiencies on the construction, they are obligated to notify the contractor. That's what that statement is saying. Am I misunderstanding that? I'm not sure what you're saying about the 06, 46, whatever that is.
Yeah, for number 6, I believe it was I would think for slides, yeah. But
no, the oil is a tool. So the oil is not required. The oil is a tool that's using. So if you have a non-compliant condition that's being constructed, all we're saying is that the IOR needs to notify the contractor in writing of that deviation of that non-compliant work. You can clarify if I'm getting that wrong, if I'm not understanding the question, but.
Yeah, so that's a good point. So the person who wrote that question, we hope that answered the question. If not, please feel free to type in the question.
Yeah, this is number 6 on the screen. All we're saying that any deviation in the work, any deficiency, deviation, et cetera, needs to be brought to the contractor's attention. If that's done via an oils list, that's fine. That probably meet that requirement. But an oil list in itself is not a requirement from us.
Perfect. And this is the next question is more of a generic question, Richard. And the question reads, are there any new provisions in Chapter 7 of the 2002 Administrative Code that will be applied retroactively to other code cycles?
It depends what it is. If it's a process, yes, it can be. If it's something like a fee change or something like that, no, it's going to apply to the project once it comes in after January. If it's process, an example would be when we did the NMA PIN, that applied to all projects moving forward, because that was just a process that we are implementing. So we're not going to track the way we're processing NMAs based on when the project was submitted. We're just going to track them all the same. So most of these changes that you're seeing in the code are more specific to the projects, and then they wouldn't be retroactive. If you have a specific example, I can answer that. But in general, it's going to stay with the code cycle the project was submitted, but there are exceptions to that.
Perfect. And we'll have a couple more questions, and then we'll move on to the next section. This next question is related to integrated review. Are incremental submittals considered integrated review from a fees perspective?
No. An incremental review is independent from an integrated review. You can have an integrated review that is incremental, or you can have an integrated review that is not. But you can also have a regular review that's in increments. So there is no fee change on an incremental review by itself. But it does have to be approved ahead of time. There is an application to approve it. That just means we're going to be reviewing it in increments versus a integrated review is more like the collaborative review, where you get more meetings, you get more access to the drawings during review, things like that. So that's why there's an added cost.
All right. And then two more questions, and then we'll move on. This is a follow-up to the administrative code question, if they're going to be applied retroactively. The individual is asking specifically CAC section 7-145 related to IOR reporting.
This is really nothing new. It's just clarification. So I'm not sure, again, I need more specifics. This has always been required that the IOR shall report any deficiencies or deviations. It's just being put into code. Same thing about on-site electronic records. We've always recently have allowed electronic records. And we're just putting that in the code so that it's clear that they can be done, but also the requirement that they are available. So again, we can address that in more detail during the Q&A at the end if you want to ask more specifics. But again, this shouldn't be anything new that you're not experiencing now. This was actually written 5 years ago and just was put in the code now because it didn't make the last cycle.
Great.
It doesn't really change the way we work from what I'm seeing. So if you're disagreeing with that, please let me know.
And then last question, Richard. This is having to do with permanent or fixed equipment. Would Omnicell/Pyxis count as fixed equipment since they are anchored units but have wheels?
Yes. And the reason is a fixed equipment or movable equipment is also considered as fixed equipment. It is anchored. It's just unanchored on occasion for cleaning or servicing. It is still a fixed piece of equipment under normal circumstances. And that's also going to be clarified in the code as well.
Great. And we do want to remind everyone that if you do have specific questions, send us an email over to that regs unit at hchi.ca.gov email. Again, that's regs unit at hchi.ca.gov. Richard, all yours.
Yeah, thank you, Cesar. Also, if we didn't get to your question yet, we will have time at the end and we'll still take questions at the end. So we will still have time to get to them. So going into part 2, volume 1, which is the building code. Here's one of the items that you'll see in this new code that is going to be removed in the next cycle. There was a purpose for this and that purpose has been resolved, but OSHPD 2, 2A, and 2B. We finally got rid of the additional requirements for OSHPD 2 back in, I think, 2016 for the multi-story buildings where SNFs were considered OSHPD 1s if they're multi-story. We put everything under OSHPD 2. Somehow in this cycle, they got some of that requirements got put back. So the way we're fixing that temporarily was to add a 2A and 2B, and basically a single story wood frame or light frame construction or buildings a single story or light frame where only skilled nursing or intermediate care facilities are provided are considered 2A. 2B are skilled nursing facilities and intermediate care facilities of all other building types. If you have a single story wood frame building, that's just a 2A building. If the code requires something that applies to both a 2A and 2B, it's just going to say OSHPD 2. So you'll see 2, 2A, and 2B. If that's a problem, we are getting rid of the 2A and 2B in the intervening code cycle as we corrected the issue that caused that. So again, that's one of the flags I'm telling you that it's going to be changed. So this language will be gone, and for the next year and a half, we're going to have to deal with it. And again, there's no additional requirements because of that. But it's just a headache that we don't want to deal with. We're going to put everything under OSHPD 2 because the requirements are still the same. One of the big things that we accomplished in the 2022 code is we're adding what's an intermediate level of procedures for both between a treatment room and an operating room, which will be called a procedure room, as well as a diagnostic imaging versus an interventional imaging. And by doing that, we're following FGI requirements of having different classes of imaging rooms, class 1, 2, class A, B, and C, sorry. So to do that, we had to add some more definitions. So we revised the restricted area definition. I'm actually going to read through these. A restricted area applies to a designated space contained within a semi-restricted area and accessible only through a semi-restricted area. The restricted area includes operating and other rooms in which operative or invasive procedures are performed. So this is your OR rooms, okay? We added a new definition for semi-restricted since we're referring to it. Semi-restricted applies to the peripheral areas that support surgical services. These areas may include storage for equipment and clean sterile supplies, work area for processing instruments, sterile processing facilities, hand scrub stations. These are your corridors outside the operating rooms, basically. The semi-restricted area of the surgical suite is entered directly from an unrestricted area past a nurse station and from other areas. Public access is controlled. Okay. So since we have a semi-restricted definition, we're going to have an unrestricted definition, and this is basically pretty much any other part of the hospital. Applies to any area of surgery department that is not defined as semi-restricted or restricted. These areas may include a central control point for designated personnel to monitor the entrance of patients, personnel, and materials into the semi-restricted areas, staffing changing areas, a staff lounge, offices, waiting rooms or waiting areas, pre- and post-operative patient care areas, and access to procedure rooms. Public access may be limited. And also we're defining invasive procedure, which means a procedure that is performed in an aseptic surgical field and penetrates the protective surfaces of the patient's body. It requires entry into an opening of a sterile body cavity, involves insertion of an indwelling foreign body, includes excision and grafting of burns that covers more than 20% of the body, and does not begin as an open procedure, but has a recognized measurable risk of requiring conversion to an open procedure. And all this is being done so we can add the procedure room level in there. Even though we're not regulating what's invasive from a OSHPD standpoint, we are working with CDPH through the functional program to identify the types of procedures that can be done in the different levels of rooms, and we'll cover that more in a little bit. So we're adding the definition of a procedure room, means a room designated for the performance of patient care that requires a high level disinfection of or sterile instruments and some environmental controls, but is not required to be performed with the environmental controls of an operating room. So this is your intermediate level type of procedure room where they might be doing needle biopsies, things like that, where you don't need an operating room. The previous definition of invasive was any penetration of the skin, and that required an operating room. And that's not where we're providing this intermediate level. And those of you that have done a lot of imaging equipment know that a lot of the diagnostic imaging rooms, once they added the definition of image guided to interventional, required those diagnostic rooms to be upgraded to a more surgical type environment. So that's why we're also adding the mid-level class B imaging room where they can do more image guided procedures without going to the interventional level. And again, we'll cover that in more detail. One of the things that we did do was also the location terminology for readily accessible has been redefined. Previously, readily accessible included directly accessible unit, which doesn't make a lot of sense. So we just changed it to located within the same department or service space as the identified area or room, located in and shared with an adjacent unit, or within 200 feet of the department or service space in an accessible corridor. So that's going to provide a lot more flexibility. An example of that would be the pharmacy toilets. They have to be readily accessible, which means they can still be within 200 feet of the pharmacy, but don't have to be directly accessible. So hopefully that'll help a lot of you out. Again, under examination and treatment rooms, we added procedure room. So the rest of the definitions are the same, and saying this, that's the heading. For under treatment room, we were asked by CDPH to add a provision that if they're using stress test machines, that it's still in a treatment room. You know, they want the sizing and the requirements of a treatment room, but you can exclude a crash or exclude the exam light, but you need to provide a crash cart for patient resuscitation. So that way we don't have a separate category for a stress test room. It's just basically, it meets all the requirements of treatment room, but if used for exercise stress testing, it includes space for a crash cart and patient resuscitation, and you do not need an exam light. Then we have all the requirements for a procedure room. I'm not going to go through them all. Procedure room, unless specifically specified elsewhere, procedure room, if a procedure room is provided, shall meet these requirements. And here's where we have the location of the room shall meet the requirements of a semi-restricted area. So the room itself needs to be semi-restricted, but the procedure room shall be permitted to be accessed from a semi-restricted or from an unrestricted corridor. So again, if we're going into like just a larger type treatment room, you can have it where it's not in the operating environment. We're also going to have the space requirements. Procedures rooms should be 130 square feet. You have to have all the clearances here. Again, I'm not going to go into all of these, but just to let you know that there are requirements for procedure rooms. They also addressed, which I think we should have in more places, the encroachments into the minimum floor area. The encroachments, this could be like a column or something that might encroach into the clear floor area required for a procedure room. Does not extend more than 12 inches into the minimum floor area. Where a sterile field is provided, the encroachment shall not extend into the sterile field, which is typically 5 feet around the bed or the table. Encroachment width along each wall does not exceed 10% of the length of that wall. So this is really good for when we're working with existing, like a remodel space and trying to convert that to a procedure room. You'll know a little bit of guidance on what that clear space would allow. Continuing with the procedure room requirements, you have a documentation area, patient privacy, and a hand washing station. A scrub sink can be used in lieu of the hand washing station, or you can have both. Jumping to med stations now, a med station no longer needs to be directly accessible from the nurse station, but it does need to be secured. You know, a card reader or a key lock has to be a secured area. This is a simple one. There was 2 airborne infection isolation requirements. One was always item 6, line 6 was always for intensive care. It just wasn't clear that that's what it was for, just because it fell under intensive care. So we're just clarified by adding the word intensive care. And then under the nurse call devices, it's always been a misconception that a toilet in a OSHPD 3 clinic required a call station for nurse call. Everyone, electrical code referred back to this table that said patient toilet room for 1226, had a dot there, says you need a call station for a toilet room in a clinic. If you actually go to the text for 1226, it never gets you there. So it's never been required, but it's often been added for no reason at all. So we're adding a subnote number 1. It says not required for primary care, chronic dialysis, rehab, or psychology clinics. So hopefully that'll end a lot of that confusion. Under the interior finishes, we're adding a new table. This is for the treatment, procedure, and OR, as well as the class 1 A, B, and C imaging. We're adding this table. So these are just the pointers to the table, and we'll take a look at the table right now. So what you're going to see added is a new table that's going to be basically broken down by exam room or treatment room and class 1 imaging. You're going to have an example of the use of those. So class 1 imaging room is diagnostic, radiology, fluoroscopy, mammo, CT, et cetera, services that use natural orifice entry and do not pierce or penetrate the natural protective membranes. But if you look at the room type, location, and the surfaces, types of finishes, they're identical for both of those, okay? When you get into the procedure room in class 2, again, you're gonna have examples of the use in each room, and then you're gonna have the rest of it, the location and how it's accessed and the type of finishes are identical for those 2. And then the same thing with operating room and a class 3 imaging room. They're going to have the same requirements. They have to be in a restricted area. They have to be accessed from a semi-restricted area. They're going to have the same finish requirements. What I want to draw to your attention is for a class 1 imaging room, it says services that use natural orifice entry do not pierce or penetrate natural protective membranes. That language, although approved by CDPH, once we went back and looked at it with them afterwards, they thought that was too restrictive. So there is a pin out, I think it's pin 73, I won't swear by that, but that corrects that language, and that is changing in the intervening code, that there's going to be a little bit more flexibility there for neobiopsies and stuff. I don't know if I have the actual language here, but the pin does have that. Okay, so the big deal here for us is adding this procedure room and class 2 imaging room. So if you have a existing diagnostic room that has migrated or is being converted into a class 2 imaging room, it can remain in the imaging department, be accessed from an unrestricted corridor, but the room itself would need to be semi-restricted. Again, our staff do not make the determination if your procedures meet the requirement of a class 2 imaging room or a class 3 imaging room, but they do, it should be identified in the functional program, and it will be submitted to CDPH to make that determination. Jumping to SPC NPC compliance, this is just a correction in a text. Chapter 34 is no longer used, so it's pointing back to 307A, and it's also in the existing building code. Simple change. In 2016, they put in a provision that all support areas for a nursing unit must be within that unit. We found that to be very restrictive for most facilities. So we've removed that requirement, but added if it is, they must still have direct access to the unit. So if you have parallel nursing units with a nourishment room, soil utility, clean utility, equipment room in between the two, as long as they have a door going into each unit, that is fine. That was causing a lot of unnecessary hardship on a lot of facilities. We're going to look at some of those examples here. Nurse supervisor office may be shared between adjacent nursing units on the same floor. A clean utility room, we got rid of the in each nursing unit. So it still needs to be accessible to each nursing unit. This just doesn't need one for each. Same with the soil utility and the nourishment rooms. Equipment storage, the same thing. Centralized bathing facilities, a lot of you, especially the owners, will be happy about this. Centralized bathing facilities always had this requirement for the special bathing facility with a roll-in shower. Basically, we're making that roll-in shower optional now. So if provided, special bathing facilities for patients on gurneys, carts, and wheelchairs shall include a space for an attendant. So it's as simple as that. So they are no longer required. They are optional. For surgical service space, we're just including sterile cores as being in the restricted area. And that is a request from industry. And this is just a pointer that if a procedure room, this is under surgery, but if a procedure room is provided, it shall comply with 1224-1426. Those are the requirements for the procedure room that we just looked at. For anesthesia, this is for your PACUs. There's always, for years and years and years, been a big debate about what is the required space between beds for egress or for transporting patients. Is it 8 feet between the beds, foot of the beds? Is it 8 feet between the cubicle curtains? Is it 6 feet between the cubicle curtains? We finally got it into code. So there should be a minimum of 5 feet shall be provided between the sides of the gurneys or beds, and a minimum of 3 feet clearance shall be provided between the foot of the gurney or bed to a closed cubicle curtain. Okay, actually, this is the only place a cubicle curtain is referenced for clearance at the foot of the bed, and that's primarily because of the use as a PACU. And then we go on to add the language, a minimum width of 6 feet of access circulation outside the curtain shall be provided. And then it just points to the patient bay under patient care locations under the definitions for a patient care station, cubicle, and a bay. But the 6 feet is required outside the curtain, the cubicle curtain. And it says access and circulation because it's not always necessary at the foot of the bed. It may be at the side of the bed, but 6 feet between cubicle curtains is required. And again, you'll see this repeated in several sections that have the same requirements. I'm not going to go over this very much, but this is the definition of the class 1, 2, and 3 procedure rooms, imaging rooms. I was saying A, B, and C earlier, so I apologize for that. It is 1, 2, and 3. And so what we're doing is saying these exam room, treatment rooms, procedure rooms, et cetera, where an imaging room is classified as class 1 or 2 procedures, the more stringent criteria that are performed in those rooms shall dictate what the room level is. So that's where it gets down to the type of procedures that are being presented. And then we also have, if class 2 or 3 interventional imaging guided procedures are performed, it points you over to the supplemental surgery area. And again, a class 2 imaging may be required to be in a supplemental surgery based on the type of procedures that's being done. But also, if they have lesser procedures, it can be in the imaging department. So that's why it's worded this way. This is also new. We've always required one fluoroscopy room as a basic service of a hospital. We are adding a CT room, can replace that fluoroscopy room as the required service, but we need approval from licensing. So it must be identified in the functional program so we can get that approval. But so now you can have either a fluoroscopy room or a CT. Now they would need to meet the seismic certification requirements for that piece of equipment to be what would be used under an emergency conditions. Okay. Language for space for processing images, we just added or viewing because everything's digital now. Hand washing stations, and this is just breaking down what hand washing stations are required for class 1, 2, or 3 imaging. Again, class 2 imaging can be either or hand washing fixture or a scrub facility or both. Class 3 imaging does require scrub sinks. Class 1 just requires a hand washing station. For radiation protection, again, just breaking down the requirements for class 1, 2, and 3. It's basically the same thing we would require now. It's just adding the information about the control stations and the control alcoves. And then again, what we base our decision on is the physicist's report. So you're still going to need that. And this language was in the code and fell out, and we're just putting it back. So where 2 or more individual imaging or therapy modalities are integrated into one imaging device, the minimum requirements for that room shall include the criteria for each individual contributing modality. So if you have 2 different types of equipment, you need to meet the requirements of both of them. And for MRIs, we added the requirements for safety zones. I'm not going to go through all the safety zones. Hopefully, if you've been doing MRIs, you understand there's safety zones are required. Zone 1 consists of the area for the general public, and as you get closer to the MRI equipment, Zone 4 is the strict area within the MRI scanner room itself. So again, this is a safety requirement for people having metal either in or carrying metal on their bodies. Those requirements have been there for quite a while, and now they're just being codified. Also, a lot of the new imaging equipment are coming out with much less equipment that goes along with it. So the equipment, the imaging equipment room, or the computer rooms that we used to call them, may or may not be needed. So it's going to be based on the type of imaging equipment you have. We're seeing a lot of the CTs are little CPU-sized boxes that can sit under the control desk. So depending on the type of equipment, you'll see a lot of language here that says an imaging equipment room. We're standardizing the wording to imaging equipment room because we've seen computer room, electronic room, equipment room, all kinds of stuff. So they're all going to be imaging equipment room shall be provided if needed for the operation of the MRI. Because a lot of the equipment no longer requires the equipment room. Ultrasound, there's some changes to ultrasound rooms. An ultrasound room is not a procedure room, it is an exam room, so we made that correction. We also added if exams performed are limited to cardiology, vascular, breast ultrasound, or used for image-guided procedures, the toilet is not required to have direct access. Currently, our requirements that there's for ultrasound, you'd have a toilet with direct access to the procedure room. That can be shared between 2 of the exam rooms. Again, a lot of the facilities said, you know, just because we have an ultrasound doesn't mean we're doing anything to do with the bladder or anything like that, or even pregnancies, things like that. So that toilet base, again, based on the type of procedures, the use of that room may or may not be required to have the directly accessible toilet. If a ultrasound room wants to have their own processing room for cleaning probes and equipment, we just added the requirements here that are similar for a processing room. in other sections, same requirements. I've made some clarifications for staff support areas. The wording before said for the lounge, locker, and toilet facilities to provide immediate accessibility to, this is for pharmacy, sorry. Provide immediate accessibility for pharmacy staff, toilets, and lockers. So we revised the language to provide pharmacy staff lounge, toilet rooms, and lockers that are readily accessible. This is where that readily accessible will help out a lot. It doesn't have to be within the pharmacy itself. So hopefully that language will help a lot of you out when you're laying out these plans. Also under dietetic service space, we added a note here that if you have a kitchen that is under construction and the facility arranges to have a temporary mobile kitchen brought in that's approved by the licensing agency to provide meals for that hospital during construction, a warming kitchen is not required. Okay. And for central sterile, this goes kind of back to the ultrasound, but there was some confusion about if a sterile processing, if each of these required work areas, soil area, clean area, storage area, had to be in separate rooms. So we just added the word distinct. So rooms and distinct spaces shall accommodate the following. So you can have a soil scope processing room that is a single room that you bring in your dirty utilities here, process them, clean them, package them, and get them out all in the same room. You just need to show a distinct area for soiled and clean, and storage does actually require a separate room. Again, under employee dressing rooms and lockers under 1225, just did a clarification here, separate dressing rooms for male and female personnel with lockers and a toilet room. The way the language was written before, lockers, lavatory, and toilet, we were seeing the lockers put into the toilet room, and they do have to be separate. So you have access to the lockers while someone's using the toilet, and vice versa. For supplemental surgery, we just got rid of the word x-ray and put imaging equipment, very simple. And here again, just changing the terminology for the imaging equipment rooms. We had electrical equipment rooms, we had computer rooms, we had all kinds of stuff. So we just changing the terminology to keep it consistent. Again, with the staff changing areas under supplemental surgery, it just said staff changing. It is male and female. Staff changing areas shall be provided. This is treated the same as surgical areas. And they can be in an unrestricted area, change their clothing, move directly into the interventional imaging suite. Again, the same requirements as for an OR. And for hybrid operating rooms, we are allowing the use of cameras to see down the bore of the imaging equipment, because in the way the hybrid operating rooms are set up, or the control station is, sometimes it's impossible to have the bore aligned with the control station. So CDPH has allowed us to provide cameras to see the patient in the bore. But right now that is only for hybrid operating rooms, and cameras still cannot be used for to replace direct visual contact in other areas. Intensive care units, just refrigerated storage is required. That wasn't in there before, but it has always been in Title 22. So we're just aligning with that. And then for the airborne infection isolation rooms, when approved by the licensing agency, an airborne infection isolation room is not required for small rural hospitals or protected environment units. And the reason, it used to say burn centers, but there's a lot of different, bone marrow units, things like that, or protected environment units. And the reason is they're already protected. Usually they're all negative pressure for those entire units, so that you don't have to have the airborne infection isolation room independently. For NICUs, way back in 2007, when they redid the code, they matched NICUs up with ICUs, which required them to have a 13-foot head wall. We realized that was never really the intent, so we put the NICUs back to 11 feet requirements for the head wall. I'm going to pause here in a second and we're going to go for more questions. But I just want to get through this piece.
Great, thank you, Richard. Going back to the, let's see, we have a question going back to notice of start of construction. To follow up on that, this individual's procedure for notice of start of construction has been that the actual form is uploaded by the DPOR with an estimate, and the actual physical start of construction is documented by the IOR via an email to the HCI compliance officer when something actually occurs on the project. Is this still acceptable, or should the notice of start of construction not be uploaded until physical construction commences?
It is still acceptable, but you should be notifying, the IOR should be notifying our staff prior to the first work on site, or for the first work, off-site either. They need to give them advance notice. It's not the day of, it's ahead of time. Again, we need to schedule our staff that may want to be there. They may have questions, things like that. So, but yeah, the process is still, the IOR typically will submit an email or a phone call, or not a phone call, email or something to the field staff to notify them that they will be starting construction on this date, on a specific date.
Great, thank you. Another question. This question is regarding OSHPD 2. The question reads, is OSHPD 2 a separate designation from OSHPD 2A and 2B? If so, then how is it different?
OSHPD 2 will be, if it applies to both 2A and 2B, it'll just be OSHPD 2. So what you're going to see is in part 1, what we're looking at today, part 2, volume 1, it's all going to say OSHPD 2 because everything applies to both. It doesn't matter what type of building it is. In part 2, volume 2, there's a lot of references to 2A and, or actually to 2B, because 2B is the more complicated, if you will, type of building. Again, if you're running into problems with that, let us know. We can do an AMC to basically get rid of that requirement, because it really doesn't apply to, I mean, what applies to a 2B won't even be seen on a 2A. In other words, like shotcrete is required on a 2B, that you have certain requirements. You're not going to be doing shotcrete on an OSHPD 2A wood frame structure. So why are we distinguishing between the two? If you're doing a wood frame structure, there's no requirement for the shotcrete. You're not going to use it. So we're getting rid of the 2A and 2B again. That's just a simple example. So it shouldn't be an issue. If it does, contact us and we can again work with you to keep everything under 2, because the requirements are all the same.
Great, thank you, Richard. The next question is related to readily accessible. The question reads, does readily accessible within 200 feet allow floors above or below?
I believe not. The way that's worded is 200 feet on the same floor.
Perfect. Going back to class 2 imaging.
Look at the language on that, readily accessible. I don't want to jump back that many slides, but there's more to it than just the 200 feet. And y'all can download copies of this handout as well from the handout window.
Yeah, perfect. Thank you for the reminder, Richard. Yeah, if you haven't done so already, the handout of this presentation, it's a PDF copy, but feel free to download that under the handout section of the go-to toolbox, where you can follow along and you can download it to review those definitions and the information that Mr. Tannehill is going over.
Yeah, and just real quick, the reason that that's on the same floor is because you have to look at the number of doors you have to go through. Once you start going above floors and stuff, you're going through stairwells, you're going up through all the stuff, and now it's no longer considered readily accessible.
All right, Richard, the next question here reads, are there any imaging functions that can be considered class 2 imaging room that is not an interventional imaging and this person quotes a section 1224.28.4 space. There seems to be some overlap.
There definitely is overlap, and that's why the requirement is that, through the functional program, they identify the procedures that are being done in those rooms. And our staff is not going to make that determination, what's considered interventional versus a procedure type room. So we would be sending it to CDPH to make that determination. So it's very important to identify the procedures that you want to use. The new, in the intervening code, we'll have, actually, if you look at the PIN, we'll have some revised language for the what's considered in a treatment room versus a procedure room, just to make some clarifications. But again, there is overlap by design, because you may have a procedure room that you're doing more intensive type procedures. That room may still be required to be in an interventional environment, but it may be still called a procedure room. So that's, again, we've been working on this probably for 6 years to get this language right. So.
Great, thank you, Richard. The next question is in regards to OSHPROD 3 toilet rooms. The question reads, with regard to nurse call in OSHPROD 3 toilet rooms, what if the aforementioned clinics, rehab, chronic dialysis, or psych are outpatient type services in an OSHPROD 3 building licensed under a GACH as opposed to an unlicensed service in an OSHPROD 3 building? Will they require nurse call if these services are licensed under the Title 22 regulations of outpatient services of GACH?
No. The clinic does not require, if you look at the 1226 and look at the requirements for a nurse call in a clinic, it's not under the clinic section. If you look at 1226, it'll say needs to meet the requirements of 1226.4 through 0.9. The requirement for nurse call is actually 0.3. So it doesn't even fall under the requirements of a clinic. Now, again, if you have a service that requires it, that's a different scenario. If you're doing something, like I said, outpatient surgery, and that can be done in a clinic space, that would require it. That's why we put the exceptions the way we did. But if you look at the actual text, you're not required to put in a nurse call into a regular clinic, primary care clinic, psychology clinic, etc.
Okay, Richard, next.
Clarification of what was there before, that there was confusion because electrical referred you to the table, which says you need it, but the table, if you look at the text, doesn't require it.
Richard, the next question reads, it's regarding to circulation space within the care suite. Section 1224.16 3.1, does this address the circulation space within a care suite, as often care suite will have corridor widths required even though care suites do not have true corridors, which require an 8-foot minimum and only circulation space within the suite? Please confirm the 6-foot minimum applies to all circulation space within the care suite.
What you'll see as we continue on, we're going to identify the clearance required for each type of environment. So a PACU only requires 6 feet between the curtains. I believe an observation unit will have its own requirements, things like that. So we will address those. So if I don't answer your question by the end, ask the question again. But if it's a corridor, it will need the 8 feet. In a care suite, again, depending on the use, it may allow you to go down to 6 feet. What we're trying to do, if it's treated as a corridor, it's probably going to be 8 feet. If it's treated in a room environment, like a PACU is typically a room that you bringing patients in and out of, the 6 feet will apply. We're going to address emergency rooms. We're going to address observation units. All of that they're all addressed individually. So hopefully that'll clear up any confusion.
All right, we have a couple more questions, Richard, and then we'll move on with the rest of the presentation. The question reads, for support areas for staff specific to pharmacy requirement, can this pharmacy staff lounge, locker, and toilet space be centralized space shared with other departments within the adjacent area?
No, the pharmacy requirements is that it's dedicated to the pharmacy. Same with dietary. They have their own requirements for that. And that's remaining the same. So the pharmacy can have, we're no longer requiring those to be in the pharmacy or directly accessible to the pharmacy, but they still need to be dedicated to the pharmacy. And there's reasons for that from a safety point of view.
Richard, the next question is related to identification of safety zones. Section 1224-18.4, how is HCI enforcing identification of safety zones only demarked on plans or physically in space with signage and or flooring or ?
Yes. It's not defined on how you define those zones. They can be through signage, they can be through visual markings on the floors, things like that. They just need to be identified. We're not telling them what that is. I've done several MRIs and it depends on the facility and how they're treating it. Most of the time I see signage, or as they get closer to the MRI room itself, the barriers become a lot more visible, if not physical, like theater type ropes that block you from entering the space. So there's different ways to do it. We're not going to define what those are. They just need to be shown on there and identified on what you want to do.
All right, Richard, 2 more questions and then we'll move on. This question reads, for isolation rooms, does HCI require anteroom? FGI does not.
For isolation rooms?
Yes, it's specific to isolation rooms. Does HCI require an anteroom?
Yes. The exception to that is there are exceptions to that. And like I said, the protective environment rooms may not require it because of the environment they're within. And it'll say in each section if they're not required. But an isolation room, as it's a general rule, will require an anteroom, unless there's an exception in the specific department that excludes it, which there are very few. Exam rooms, protective environment rooms, things like that do not require it.
All right, Richard, and last question. The question reads, continuous inspection of work. Electronic records may be retained off-site if made available during on-site remote review of documents. Does that mean that remote review is only needed if the records are maintained off-site, or if they are kept on-site electronically, do they also need to be available remotely?
What it is saying is that if you're going to keep the records electronically, they have to be available when the field staff asks for them. That's all we're saying. You have to be able to present them, be that in person, on site, pull up a computer, a laptop, open them up, or if you're having a Teams meeting or a go-to meeting or whatever, and they ask to see the daily reports or something, they have to be able to have access to them and share them. If you can't share them, then you're not meeting the requirement.
Perfect, Richard. And we do have a couple of more, but we can save those towards the end if you want to continue.
Yeah, should be pretty quick from here through. And like I said, we will have time for Q&A afterwards. Okay, continuing on, pediatric and adolescent nursing units. This is an alignment with Title 22 that has not been in the code previously. Patient rooms and pediatric units must have direct visual observation between either centralized or distributed nurse stations or workstations or by other means approved by licensing agency. The question I've been getting over and over again is, does this like an ICU where you have to have visual observation to the patient's head? The answer is, as of right now, you just have to be able to see the patient in the bed. Basically with pediatrics, you want to make sure the kids are staying in the bed where they're supposed to be. You don't want them running around. Whereas ICU is a different requirement to see the patient's head to make sure that they're still functioning. In addition to that, there was a requirement for exam room or treatment room in pediatric units. Title 22 has always said exam room and treatment room. So you must have an exam room and a treatment room in a pediatric or adolescent nursing unit. We've actually had a facility get caught on that in the last year by just putting in one. So again, we're making that correction to hopefully avoid any other facility running into the same problem. In addition, the playroom, which used to say play area, Title 22 actually requires a room, not an area, in the adolescent and pediatric units. And they also must have direct visual observation. Again, they must be monitored for the patient safety. Psychiatric nursing units, this is in 1224. Just added some clarification that requirements under 1224.14 are for a unit that provides acute medical care, where the requirements of 1228.14 are for a non-medical unit, which is your standard psychiatric unit. There seems to be a lot of confusion on why do we have two sections for psych, 1224.31 and 1228. And 1224.31 is typically a distinct unit of a hospital that they are treating psychiatric patients for medical conditions. So these would be, you still have all the requirements for medical care. 1228 is your ambulatory typical psychiatric unit where you don't have the same requirements. In a psychiatric unit, both 1224.31 in both a hospital as well as a ambulatory psychiatric unit. For occupational therapy, we're eliminating the activities for daily living requirement, item 4, from those. So we're just saying you must comply with 1224.35 for rehab for items 1, 2, and 3. This is for occupational therapy. The activities for daily living is primarily for people that have amputees or some medical condition that they're learning to restructure their lives and live at home independently. In a psych unit, that isn't really required, so that has been eliminated. And again, another alignment with Title 22 is the requirement that in a psych unit, the beds shall not exceed 90 linear feet from the nurse stations. That fell out of the code years ago, and that should have never been removed. And again, that's because of a safety factor with observing patients. Under obstetrical facilities, this question comes up all the time. There was an exception for LDR and LDRPs. If you had an LDR and LDRP unit, they may be counted as a delivery room in the postpartum bed ratio. Under delivery rooms, at least one delivery room shall be provided. By adding an LDR or LDRP, that does not exempt the requirement for that delivery room. You still need at least one delivery room. Okay, so we just added that line. It says this does not exempt the delivery room required per 1224.32 above. Under emergency services, here again is where we're having the clearance between the cubicle curtains. Again, this is treated the same as a PACU. You have a minimum width of 6 feet of access circulation outside the curtain shall be provided. As I said, we're going to address these independently because they're a little different depending on where it is. And then again, this is only for the multi-station rooms, obviously. And it wouldn't matter if it was in a care suite or a emergency room, so to speak, an actual room. For observation area, same thing. There's a little different wording here. For the observation areas, the dimension and arrangement of the rooms, and this is, again, we're trying to align these more with like a patient room in this case. You're going to have clearances of 3 feet between the sides and any wall or fixed obstruction, and a minimum clearance of 3 feet between beds, and a clearance of 4 feet shall be available at the foot of each bed to permit passage equipment. Again, if you recognize that language, it's the exact same as for a patient room. Medication preparation rooms for emergency in an emergency department must have a minimum of 1 medication prep room. Okay, that does not mean you cannot have self-contained medication dispensing units as well. But they're in an emergency room, there must be at least one med room for security purposes. That may change in the future, but as of right now, that aligns with Title 22. You must have one med room, but you can have, once you have the one med room, you can have Pyxis or Omnicell units throughout the ED. For the pre-screening stations in an open bay pre-screening area, one hand washing station shall be provided for every 4 patient stations. Again, the requirements for the hand washing stations wasn't there previously, so we're just adding that. And that, again, aligns with other areas of the code. For observation units in the emergency department, again, this is just the clearances that are required. Before, we only had requirements for a patient room. We didn't have requirements if these observation units were multi-station rooms. So we're adding those requirements to multi-station rooms shall provide 80 square feet per patient station with a minimum of 8-foot width. You have your clearances between the sides of the bed. And patient gurneys shall be separated from adjoining patient stations by curtains. So basically similar requirements as a patient room itself. But before, they're only allowed you to have single patient rooms the way it was written. So we basically changed that. So this matches the outpatient observation unit language. So they're identical for outpatient observation unit under 1224-39, as well as the observation units within the emergency department. For nuke med, again, changing the words from computer equipment to imaging equipment, removing the redundant word of scanner room, and also changing the language for a SPECT CT to align with that as a PET CT. Basically, both of those types of equipment may or may not have a CT unit on it. So if there is a CT unit as part of the SPECT or the PET equipment, you do have to meet the shielding requirements. And what you'll find is that even if you, any type of SPECT or a PET scanner going in, we are going to request a physicist report to show if any radiation protection is required or not. And what we're finding is a lot of the units without CT scanners built into them, the facilities want to put the techs into the room, procedure rooms with the patients, which is fine, but we're going to need verification from the physicist report that that is, there's no danger to the tech. Continue on with nuke med. Again, the clearances for the recovery area for radio surgery suite, minimum of 6 feet of access circulation around the curtain shall be provided. And the requirement for the med station to be directly accessible from the nursing station here has been removed as well. A processing room, this is for outpatient services under 1224-39, the same requirements for as in the 1220, the regular sterile processing, that shall provide distinct areas for cleaning, decontaminating of instruments. Removing the 0.3 on here, simple change. There is no, 16.3 is a very specific item, but the PACU requirements is to the whole PACU section, not just to the 0.3 section. Under 1224-39-36, the service areas for a GI endoscopy unit shall provide all support areas required under 1226, which is the outpatient requirements, if the existing department does not already have them and can be shared with them. So this is kind of backwards. We're usually pointing back to 1224. In this case, we're pointing forward to 1226. We've always got the question, why are there more requirements in the clinic GI endoscopy department than there is for the hospital? And the reason is the hospital can share functions with that already exist within the hospital, be it in the imaging department or elsewhere. There's a lot of the requirements for a GI unit that can be shared. If you're doing a standalone clinic, you have to provide all those extra services to make sure that's fully supported. So what this is basically saying, if you don't already have those in the hospital, you still need to provide them to match what's required for a clinic as a standalone unit. Continuing with outpatient services. This is, again, just a clearance is required for outpatient observation unit, just adding the language to match the other sections to say that the walls or other fixed obstructions for access circulation. Just adding the word access circulation because we just want to make sure that the paths they're using to transport gurneys through there have the clearances required. So it's the exact same language that'll be for the patient rooms. Jumping to skilled nursing facilities. If there are central bathing facilities in a skilled nursing facility, there must be a private toilet directly accessible to each multi-bathing fixture. So this is so that the patient or the resident doesn't have to leave the shower room, go out into the corridor and back into the toilet if they need to use the restroom while showering or whatever. So that is a new requirement. Jumping to clinics. Just again, this first part is aligning the clinics with the same text that you're seeing in psych and for SNFs, just wording, nothing changing. For clinics, for HIPAA reasons, we are matching 1224 for the STC ratings on walls and certain types of rooms. So we're just referring back to that same table. Correcting a pointer for GI, pointing back to 1224 housekeeping room. This section no longer exists. And for oral surgery, this requirement before is if oral surgery is performed, it must be supplemental surgery, and that's really not what was ever intended. So we're adding the same requirements for 9.2.1 that if more than 5 patients at a time are incapable of self-preservation, then you have to go back to the supplemental surgery requirements. But if you have a dental office that they're happening to perform oral surgery and have 1 or 2 patients in there, nothing additional is required. Jumping to psych units now, we've actually made a few changes to psych units to make them less in alignment with acute psych or with acute care hospitals, just because the equipment requirements are different. One of the things we're adding is soft doors can be used for patient toilet rooms. We're indicated, and this is patient toilet rooms is specifically the toilet rooms off of the patient rooms, but it must be indicated in patient safety risk assessment. And these soft doors are collapsible doors so that they're anti-ligature. This is another area I want to point out that's going to be put back. Just there was a misunderstanding between us and CDPH when we made this change. We removed the where provided for physical therapy, occupational therapy, and speech pathology, just because in Title 24, Title 22, the way it was worded was that these things were required to be in a psychiatric hospital, and we found out afterwards that they're not. So we're going to put the where provided back in. But basically what I want to point your attention to here was, again, the activities for daily living is not required for an acute psychiatric hospital. So just for clarification purposes, PT, occupational therapy, and speech pathology are optional in a psychiatric hospital. So if you run into that during plan review or otherwise, it is not required, but if provided, you have to meet the requirements of 1224 for those services. Continuing, like I said, we made a lot of changes to the storage requirements for psychiatric facilities, as well as the room sizes. Per Title 22, no hospital room can be less than 110 square feet. So we increased the 100 square feet to 110 square feet. for a psychiatric patient room. But we also made it so that you don't have to count or exclude the bed from that square footage count. So you actually, it works out kind of a wash on those. Equipment supply and storage shall be provided for storage of equipment for patient care. Each unit should provide not less than 15 feet. It used to be going back to the 1224 where you had like 20 square feet per bed. All you need is an equipment closet on each unit of 15 square feet. So that's a huge savings of space there. We got rid of the gurneys and wheelchairs in a psych facility, but you'll see some of that popping up later. We added a whole storage section to the psych. And again, it's actually a lot less requirements. For dining area, you must provide patient dining at 20 square feet per bed, separate from staff dining. The way this was worded before, separate patient dining room shall be provided. It needs to be separate from the staff dining. Those are two independent spaces. So just adding some language to clarify that. Continuing with the storage section, as I said, we pulled this over from 1224. It used to be just a pointer to 1224-23 storage, which means that a psych hospital had to provide all the same requirements as a general acute care hospital, which seemed to be overkill. So what we did, we pulled in its own section. We reduced the number of general storage to 10 square feet per bed versus 20. So we cut it in half. Again, the specialized storage, the linen is at 10 square feet. It's per unit, and the supply is 15 square feet per nursing unit. Wheelchairs, here's what's showing up again. We do need a space to store wheelchairs. And food storage is the same as 1224. So we lessened the requirements for storage by quite a bit in a psych facility. And we also added in the 1224-31 psychiatric requirements, there was a requirement for basically a classroom. We put the same requirement for a full acute care psych hospital, or acute psychiatric hospital. So if it treats children of school age over a period of 1 month, they need to provide a classroom and an office for the teacher. So the same language that was in 1224 was added to this. And chapter 15 for roof assemblies is still in part 1. Just a change in the requirement for photovoltaic panels, that they shall be listed and labeled in accordance with UL 1703, et cetera, and shall be installed in accordance with manufacturer's instructions. It's just been, it was relocated from another section. And that's it. So we can open it up for questions. Again, if you're AIA and you want to get your credits, please contact your AIA office or submit them through them. We do not do that, but they are pre-approved through the AIA.
Great. With that, Richard, I'll go ahead and read a question pertaining to the AIA credits. The question was, how will my participation in this will this be recorded or documented for me to receive AIA learning credits? And the answer provided was the AIA Continuing Ed Credit. AIA California is provided with a list of attendees following the webinar. They handle the AIA member reporting, and the certificate of completion is your record for self-reporting.
Correct. And the catch there is your certificate of completion, you get 1 per logon. So if you have 10 people sitting with you right now, you're only going to get the 1 certificate, but so you'll need to self-report at that point. Okay.
So going back to the most recent questions that we got, Richard, the question reads, are cameras an acceptable way to provide visibility to PED patients, specifically if remodeling an existing PED unit where the current configuration is not set up for direct line of sight to the bed?
The answer is no. We may see a change in that in the future. When we were working on the hybrid OR requirement to allow cameras, I actually asked that question, and I was told no, it does not replace any type of patient safety measure for direct line of sight or direct supervision for patient care. And that's also for waiting rooms. If you have a waiting room off of a corridor, same thing applies. We are looking at getting that changed in the future, but we are definitely getting pushback right now.
Okay, and
If it's an existing facility, sorry, Caesar, if it's an existing facility and it wasn't provided before, we would have to address that on a case-by-case basis.
all right. Next question regarding ICU rooms. Emergency room and ICU rooms, they like observation. However, sliding doors can have issues both with emergency egress and are usually not sealed properly for air balance. Is there any criteria on these types of doors?
That's kind of a general question that doesn't have anything to do with what we're talking about, but as a general rule, if an ICU door is they're typically required to be smoke sealed. So they do have sliding doors that can be sealed. Again, I'm not following the question, I don't think.
Yeah, that's a good point, Richard. This is a good example of a question that is not specific to this presentation. So if you do have a question about this issue, feel free to send us an email over to the regs unit at hchi.ca.gov, and we can better answer that question there, or maybe have an offline conversation, a phone conversation, a Teams meeting, however we can help you out with that. So feel free to send us an email and we'd be happy to help with that. So Richard, going back all the way back to the start of the presentation regarding notice of start of construction. The question reads, was it stated that a permit is required to set up containment?
No. You can, that's the part. The question was, does a permit, does a containment signify start of construction? And that's no. Also, you can provide containment without any permit or anything, but that doesn't signify that you're starting construction either. You have to actually be doing something physically to the site for the further development of the project. Containment can be set up now for a project you're going to start 2 years from now. We don't care, as long as there's not any blockage to egress or anything like that. So no, a permit is not required for containment.
Great. We do have a little under 20 minutes, so we'll try to get through all these questions that we have. Again, Richard, this question goes all the way back, and it's pertaining to equipment fees. What is the percentage of the imaging equipment fee?
It's not separate anymore. In the past, it used to be a separate line item. Now it's included in the construction cost. So it's still 1.64%.
So this is a separate individual, but it has pertaining to the same question. In the project application, the construction cost and imaging cost are separate. Why is the imaging equipment being rolled into the construction cost?
I didn't think it was separate anymore. I'd have to look at that.
All right, and let's say this question reads, let's say the pad for a generator is completed or not completed, but can start of construction be considered when a PO was signed by the GC with the vendor to purchase? Also, what if the wait time for the generator is a year, hence no construction? Is that what is current?
That's something you need to work out with our field staff. If the project is only to install that generator, there's probably going to be some leniency given there. We do know that a lot of the items are quite a lot of lead time on some of these items. So we're aware of that and we will work with you on that. But if there's other work being involved, again, a purchase order itself typically does not signify start of construction. If you're manufacturing something, such as, like I said, I use the example of an elevators because they're specifically built for that site, that project, that would. Or if you're just ordering a generator that can be used anywhere, that doesn't necessarily signify a start of construction. But if you run into a situation where you have long lead items and you have a permit to install a generator, definitely talk to us.
Richard, this question is trying to get some clarification regarding the IOR field records. The question reads, CAC 7-145A6, which is the IOR field records. The question is, will this be retroactively applied to all projects regardless of the code cycle? Would this be considered a process?
Yes. Again, I'm going back to we're not requiring anything new. We shouldn't be requiring anything new. You should have been able to provide your daily reports upon our visit or upon our request, even now. So it's nothing new that's being asked for. It's just being put into code. But the answer is yes, it's a process. It will be applied to all projects.
Perfect. The next question is related to airborne infection isolation. The question reads, are airborne infection isolation treatment rooms designed to match the design requirements for the airborne infection isolation rooms?
Are the what?
So let me read the question again. The question reads, are airborne infection isolation treatment rooms designed to match the design requirements for the airborne infection isolation rooms?
Treatment room, again, that's not part of this presentation. Treatment rooms are handled differently than isolation rooms, patient rooms. You don't have an anteroom on a treatment room. But you probably have to send in that question to get a specific answer because I don't know the answer offhand.
Great, Richard. We have two more questions that we can go over. We have about a little less than 15 minutes in this presentation. So if we don't have any more questions, we will go ahead and end the presentation early. But if you do have a question, feel free to type that question into the question box of the GoTo panel. If not, and you want to have an offline conversation, feel free to send us a request or a question over to regsunit@hchi.ca.gov. Richard, the next question reads, oftentimes the cost of imaging equipment, X-ray, MRI, CT scan, etc., are extremely high and often does not take any more time for plan review and field observation than lesser cost, larger fixed equipment. It does not seem fair to the healthcare provider to pay such high fees for imaging equipment.
This was something that was decided a long time ago. Like I said, they used to be separate, a separate line item at a lesser fee. At some point that was changed. I don't know the history on that. I do hear that quite often, that it is what it is right now. I don't have a better answer for you than that.
Great, thank you, Richard. The next question, and will be the last.
Following up on that, a lot of times there's a lot more work involved in installing these and reviewing them than meets the eye. Because you see just a piece of equipment that's going in, it's anchored, but there's a lot of room requirements, a lot of anchorage requirements. There's a lot of diagnostics going to the structure it's anchored to, but they also change out a lot. You know, when you're doing a big project, you may change your equipment 2-3 times before it's actually installed. So, I mean, kind of that might be some justification, but that's just off the top of my head. So, sorry, Caesar, go ahead.
Richard, related to pieces of equipment, if the project is to seismically anchor a roll-in piece of equipment, for example, a lab refrigerator, and provide electrical service, is the cost of the equipment to be included in the construction cost?
Yes. What isn't included would be your crash carts, your IV poles, your chairs, your beds, things like that, that are just brought in afterwards. Basically, when you go to get license or staff in stock, everything that's installed prior to that would be considered part of the architecture of the building. If you have your Pyxis machines in, you have your imaging equipment in, that's what we are inspecting to, and that's what the fee is based on. Could we review it? We inspect, or we don't inspect, but the IORs inspect to that and we verify that. Once they get that approval, then they bring in all this other equipment. That's what's not included.
Richard, related to cost, is the 1.64% of for medical equipment cost include installation cost or just material cost?
Okay, again, medical equipment costs wouldn't be included in that. The fixed equipment costs would. So what was the question again? I can maybe cipher that.
Yeah, the question, it reads, is the 1.64% for medical equipment cost include installation cost or just material cost?
Actually, if it was like imaging equipment, it's both installation and material. Same with Pyxis, same with the refrigerator example. It would be both.
Perfect. Richard, I'm going to ask this question anyway, but I don't know if we have the answer for that, but we may have to refer it back to CDPH. But the question reads, does CDPH provide a list of procedures for Class 2 versus Class 3 so we can assist our clients in making the determination during the design?
No, they do not. We have been working with CDPH quite extensively, and it's ongoing to develop some guidance just for our staff so that we can better assist you as well. And the list is so long, it's impossible, because you may have a procedure done at one facility that's done a certain way, and it's done in another facility a different way that puts it into a different classroom. So that is not something that we want to provide. Just because it's going to be that list is ongoing and it's ever changing. Unfortunately, that's why we want the functional programs up front so that we can get them in front of CDPH to review those. Unfortunately, I know the pain you're feeling on this, because unfortunately, it's probably even depend on the medical consultant that's reviewing it and how they perceive it. And I say that from experience because, like I said, we've been working on this for years, and with the change of personnel, we're getting different interpretations on what it should and shouldn't be. That's why we have to actually have the PIN in the code change, because what was approved by CDPH at one point, when someone else looked at it, felt it was too restrictive, and I agree with that, but we had to make that change. So to provide a list, first of all, it would be thousands of procedures, and secondly, it would be impossible to keep up to date. But we're trying to get some guidance just so we can better assist you from our staff's point of view. But at the same time, as I said earlier, I don't want our staff making the determination of what would be fit into these rooms versus, and then have you do something and get it not approved when you try to get it licensed. So that is something why we want to get it in front of CDPH early on. And I know that'd be huge help when you're guiding, trying to get some assistance to your clients. But those are conversations you can have early on and bring to the table early on. I'd highly recommend that. It's a good question. I do want to step back to the equipment cost real quick, if I may. A lot of these questions are basically about, the cost of the equipment versus the cost of installation. If you have a project, the facility is doing a construction project to install, say, a walk-in refrigerator, they have to buy that refrigerator, they have to install it, they have to do everything, provide power for it, all that. That is a construction project. So that is what the fee is being based on. Same with imaging. Those are all in their construction budget. So that's what we're looking at. The construction budget includes those costs of those equipment. And again, like the IV poles, the chairs, the beds, all that's not in the construction budget. That's equipment that they bring in after the fact. So trying to think of it that way might make a little more sense. It's part of the construction project. It's included in the construction cost.
Perfect. That's good information, Richard. Thank you for sharing that, and we hope that that was clear. If not, feel free to send us an email. We can go ahead and further that conversation if needed. Richard, the next question is a general question dealing with code adoption cycle. The question reads, can you circle back to the adoption timelines to help us identify when the design and facility community can get engaged in the rulemaking and amendment process?
Yes, actually I can. Let me jump back to the very beginning slide, if I may. So bear with me as you flip through a million of these slides. So this is where we're at now. We're at the intervening code cycle we submitted on December 1st. Today, we're submitting the intervening cycle. So it's not too late, but we actually run everything we do through the hospital building safety boards, codes and processes committee. So if you want to be involved with this process, attend those meetings. You can subscribe on our website to get notices when those meetings are, those committee meetings, and we walk through every line, every word that we present to you today that's been approved has gone through them first. Once that happens and we submit, as I said, on December 1st, we submit this in January, February, I think it's the end of January and February this year, and March this year. This next piece here is where we have the Code Advisory Committee hearings through the California Building Standards Commission. And that's where we present all these changes, the new proposals to the commission, the committee, and they vet us and question us and basically either concur or make recommendations. And that's also a point where the public can chime in and give their comments or feedback as well. Once we get through the CAC meetings, we go to public review for 45 days. That's another opportunity for you to get engaged and make comments. And any comments we receive from the public, we have to respond to. So we either going to accept or deny or modify the codes based on those comments. And if we do so, we go out for another 15-day review after that. So you'll have another opportunity. So there's a lot of opportunities for you to get involved, and we actually welcome it. What you're seeing in these code changes are based on the questions I get every day, based on the problems that we see in the field, and based on the AMCs that we see coming in. We're trying to eliminate those bits of confusion and bits of interpretations that cause these problems. So everything that you're seeing has come up as an issue. And this is our way to try to help simplify and resolve that. And we work with the California Code Advisory Committee or Clinic Advisory Committee for clinics. We work with CAF for SNFs. We work with many facilities for psychiatric care have made a lot of these suggestions. We work with the hospital facilities for with the different systems that we meet with them quarterly, and they request changes. We meet with CDPH, they request changes. We meet on, I'm actually assisting CDPH with their revision of Title 22 so that we're making sure that we're in alignment. So a lot goes into this, but most of it now are, other than responses to changes in legislation, are done based on issues that we're seeing every day. Again, like this has been a huge legislative year. We actually have some emergency regs that are going into the intervening cycle that may or may not be good. I'm not going to make a decision on that. But there's a lot of processes. So you can get involved through our HBSB meetings, and you can get involved through the CBSC process as well. That's on the screen here. Like I said, if you go to our website, look at the top of the page and it says subscribe, you can pick that and enter your name and just click the boxes that you're interested in, and you'll get notices for those meetings.
That's a lot of good information, Richard, and a good explanation. We are receiving some questions, a little more questions on the code adoption cycle. So feel free to send us an email, and we can have that discussion offline. We do have two minutes left in this presentation. We'd like to answer some more questions that have been posed. So send us an email. That's a great question. We encourage all to get involved. You know, provide your input in the design and the creation of these regulations. So that's great to hear that you are interested in finding out the way it works, because more input encourages more discussion. So with that being said, Richard, we do have a question here that is specific to the pre-op and PACU units in an ante-room. So does a pre-op or PACU isolation room require an ante-room?
Again, there's no changes in the code reflecting that, but I'd have to go back and look. I believe there is an isolation room requirement in not pre-op, but might be in PACU. I'd have to check. That's not part of this presentation, so please send me an email and we'll get that answered for you.
Perfect. And the question is the next question regarding the preliminary review. What is the best way to initiate review of imaging procedures by CDPH to confirm imaging room class, a preliminary review with a functional program?
Yes. So that's the way to get ahead of it. Yes. I highly recommend preliminary reviews for almost any project. If you have any questions at all, you get those reviewed early on and get a good head start on your project. And we can engage CDPH if necessary. There's also a question here about pre-design meetings. Collaborative review or integrated review does not replace the pre-design meetings. You can have a pre-design meeting on almost any project. There should be a reason to have that meeting, but you can have a pre-design meeting on any project to let us, to answer questions. We're always available to help out.
Perfect. That was going to be the next question that I was going to read. Richard, you beat me to it. So with that being said, it is 11 o'clock. We would like to wrap this presentation up. Richard, is there anything else you'd like to add?
I just want to thank you all for your time, and please send your questions to Regs Unit at hchi.ca.gov if you have any questions. We're saying we're going right into the intervening code cycle, so we'll probably be doing some presentations on that soon as well. So, subscribe to our information. There's a lot of webinars coming up this year, as well as we're looking at maybe redoing the in-person seminars. So thank you all very much for your time, and have a good day.
We hope that that you found this information very helpful. Remember, if you haven't done so already, feel free to download the PDF copy of this presentation that has all that great information that Richard shared with the group. Under the handout section of the GoTo toolbox there, it is a PDF. You are able to download and print or save, and we hope that you can do that to access that information. If you do have a question, as Richard mentioned, send it over to regsunit@hchi.ca.gov. We also put that email address in the chat box if I spoke too fast. And it has been a pleasure being with all of you today. Thank you for what you do and doing your part in providing an access to safe, quality healthcare environments throughout the state of California. Richard, thank you for the presentation, and thank you all for being here. We hope that you found it useful and informative. Have a great day.